Hello, everyone, and welcome to today's webinar. It is called Multiplex Proteomics using Proximity Extension Assay for Identification of Protein Biomarkers Predictive of Acute Graft-versus-Host Disease in Allogeneic Hematopoietic Stem Cell Transplantation. My name is Dale Yuzuki. I'm from Olink Proteomics. I'll be today's moderator. This particular web seminar is presented by LabRoots. It's brought to you by Olink Proteomics. I'd like to just take a few moments at the beginning of this webinar to talk about Olink in general. Our new slogan is revealing the truth of human disease, protein by protein. And what Olink Proteomics offers is a remarkable assay called the Proximity Extension Assay that is scalable from a handful of protein biomarker targets to literally thousands. It's a form of immuno-PCR where DNA is conjugated to antibodies. And as you can see from the diagram on the left, there's a pair of antibodies that lend exquisite specificity and sensitivity. The readout is via actually a DNA that's barcoded. And as you see from the hybridization of the DNA, it's the proximity of two different antibodies against the same protein biomarker that end up being amplified as a DNA digital readout signal. And what we've been able to do is use this particular technology that offers a unique set of benefits around three particular kinds of products, which we call Explore, which is 3,000 biomarkers. Target, we have 15 panels of 96-plex protein biomarker targets, as well as a 48-plex. We have Olink Flex, which is a 20-plex, where you mix and match from 15 to 21 targets out of a library of 200, and Focus, which is a complete custom panel. The bottom right shows a software package we call Olink Insight that gives you pathway information to help the analysis of all this protein biomarker data. And just to illustrate this graphically in terms of what Explore does, Target, and Flex, this particular PEA technology scales from, like I mentioned, 3,000 all the way down to a completely custom panel. And the beauty of the technology is that it's built to scale both in terms of marker number as well as samples. Lastly, just the slide points out that the technology gives high sensitivity, wonderful specificity, uses very small amounts of sample, which for some applications becomes really important, and a very wide dynamic range. We have the privilege of hearing from Dr. Frank Michelis. He's from Princess Margaret Cancer Center in the Department of Medicine at the University of Toronto. And Frank, you may now begin your presentation.
Thank you, Dale. Thank you so much for your kind introduction. I'm going to speak to you today about protein biomarkers that are predictive in acute graft-versus-host disease in allogeneic stem cell transplantation. This is the hospital where I work at. I am a staff hematologist and associate professor with the University of Toronto, and I'm at the Princess Margaret Cancer Center, where we perform over 200 allogeneic stem cell transplants per year. We are one of the largest allogeneic transplant centers for adults in Canada. These are my disclosures. And during the course of today's talk, we will devote some time to overview what allogeneic stem cell transplant is, as well as one of the major complications of transplant, which is acute graft-versus-host disease. We will also run over a few of the fundamentals of biomarker discovery, and we will look into the use of proteomics and allogeneic transplant and biomarker research, in particular in the context of predicting acute graft-versus-host disease. So this is a brief overview of what it is that we do in allogeneic stem cell transplantation. Allogeneic transplant is reserved mostly for malignant hematological diseases. However, also for some benign hematological diseases as well, such as aplastic anemia. And in brief, what we do is we administer conditioning chemotherapy, which targets leukemic cells as well as creates room in the bone marrow for the expansion of stem cells, which are infused on day 0, following which is a prolonged course of aplasia, where patients are vulnerable to infections and other complications until the time of engraftment. Upon engraftment of the stem cells and reconstitution of the peripheral blood counts, patients are then discharged. However, complications can still occur, including graft-versus-host disease and other types of infections. So the more frequent complications of stem cell transplantation include the conditioning regimen toxicity, veno-occlusive disease of the liver, multiple infections, as I previously mentioned, graft failure, of course, and graft-versus-host disease. And graft-versus-host disease is one of the most significant and potentially devastating complications that can occur after transplant. And as we perform more and more allogeneic transplants every year, you see here this graph from the Center of International Bone Marrow Transplant Research Center demonstrating how exponentially the number of allogeneic transplants increase. Along with that, we see a significant increase in the complications, including acute graft-versus-host disease. Now, why does acute graft-versus-host disease even occur? We see this when the transfer of tissues between normal individuals occurs. The recognition and destruction of this foreign tissue is known as the host versus graft effect, which is what leads to graft failure. However, there are immunologically competent cells in the graft, and these can initiate an immunological recognition in the direction of the host, hence graft-versus-host disease. It affects up to 60% of allogeneic transplant recipients and can account for up to 20% of deaths in this population. And again, here we see some data from the CIBMTR demonstrating that in both the fully matched sibling donor transplant setting, as well as the unrelated donor transplant setting, CIBMTR, the GVHD accounts for approximately 20%, 1/5 of deaths. Now, for graft-versus-host disease to develop, there are certain requirements, sort of fundamental principles of how GVHD occurs. The first requirement is that the graft must contain immunologically competent cells. So these are mature T cells that are present in the stem cell graft, and it has been found that the number of donor T cells that are infused in the graft correlates with the severity of graft-versus-host disease. The second requirement is that the recipient of these T cells must be incapable of mounting an effective defense. So the most frequent setting in which we see graft-versus-host disease is in the allogeneic transplant setting. And there are certain risk factors associated with that, which we will discuss further down. More rarely, we can see in solid organ transplants or certain solid organ transplants, you can see the occurrence of graft-versus-host disease, particularly in small bowel transplant. And very rarely, fortunately, this can occur even with a simple blood transfusion, such as with non-irradiated blood products administered to neonates or immunosuppressed patients, or even blood donation from one relative to the next. The third requirement for the development of graft-versus-host disease is that the recipient must express tissue antigens that are not present in the donor. And the tissue antigens that are most important here are the human leukocyte antigen system, which are products of the major histocompatibility complex. And these are expressed on all cells and are particularly important for T cells. Other antigens that are also significant in the development of graft-versus-host disease are the minor histocompatibility antigens. They can also be recognized as foreign. And these discrepancies in antigen expression are what's responsible for the development of GVHD. It can even occur between genetically identical individuals, as epigenetic changes after birth can also lead to differences in expression of certain antigens. So the HLA antigen system is encoded in the short arm of chromosome 6. And basically, it is what we try to match donors and recipients with in order to decrease the chances of graft-versus-host disease and graft rejection. And basically, we'll look at matching at class 1 HLA, that's HLA A, B, and C, as well as class 2 DR and DQ antigens. Non-HLA genetics are also involved. I previously mentioned minor histocompatibility antigens, as well as the KIR gene system, and even differences in single nucleotide polymorphisms related to cytokine genes, cytokine receptor genes, or cytokines related to the innate immune system. Now, how does graft-versus-host disease develop? It is believed that the initial tissue injury occurs with a conditioning chemotherapy regimen. This damages host tissues, and in particular of the gastrointestinal tract or the skin or the liver, among other organ systems. This host tissue damage releases a number of cytokines such as TNF-alpha, IL-1, and lipopolysaccharide, which leads to the activation of the host antigen-presenting cells. These host antigen-presenting cells interact with donor T cells, activating them, and ultimately leading to cellular and inflammatory responses that lead to target cell apoptosis and ultimately tissue and organ damage. B cells also play a role in the development of graft-versus-host disease via antigen presentation, cytokine secretion, and antibody production. Now, the immune system does have mechanisms of central deletion of autoreactive T cells in order to moderate these inflammatory responses leading to GVHD. Loss of the normal thymic repertoire contributes to development of GVHD. FOXP3 regulatory T cells, or so-called Tregs, they're found to be very important in suppressing graft-versus-host disease, but a loss of these regulatory T cells is associated with worsening grade of graft-versus-host disease. Now, graft-versus-host disease can be classified as acute or chronic. This classification is sort of historically being defined as acute, occurring up to day 100 after stem cell transplantation, and chronic after day 100. However, you can have late acute onset of graft-versus-host, as well as early classic chronic manifesting as so-called overlap syndrome. We're going to focus mostly on the acute graft-versus-host disease in this talk. So acute GVHD primarily affects just a few organs that we're going to focus on. Skin is affected in around 81% of patients that develop acute GVHD, and in 44% of cases, just the skin. So this can manifest as mostly more frequently as a maculopapular rash or even a diffuse erythema, the extent of which we use to determine the stage and ultimately the grade and severity of acute GVHD. The differential diagnosis of acute GVHD of the skin also includes things like toxicity to chemotherapy or viral infections or reactions to drugs. And histologically, what we see is lymphocytic exocytosis into the epidermis, as well as the presence of apoptotic keratinocytes. Acute GVHD very frequently also affects the gastrointestinal tract in around half of the cases. And histologically, what we see again here are apoptotic bodies in the base of the crypts, crypt abscesses, and the loss and flattening of the surface epithelium. Clinically, what we see in lower GI GVHD is abdominal cramping and pain, significant high volume diarrhea, hematopoietic, as well as possible ileus in more severe cases. And the severity of GI GVHD is determined by the volume of diarrhea. However, there are numerous other diseases that need to be included in the differential, such as C. diff colitis, CMV enteritis, or even post-chemoradiation effect that usually occurs in the first 2 weeks after transplant. Acute GVHD can also manifest in the upper GI. It's a variant of GI GVHD, manifesting as nausea, vomiting, anorexia, and dyspepsia. And the differential here can also include viral infections such as HSV or Candida esophagitis, gastritis, and chemoradiation effect. And the best way to determine what the etiology is of course, pathologically by biopsy. Then we have liver GVHD, which also manifests in about 50% of the cases. And this histologically is manifesting as damage to bile canaliculi and cholestasis. The differential includes veno-occlusive disease, toxicity from chemotherapy, as well as viral infection from a variety of viruses. Now, what are the risk factors for GVHD? Because the risk is different from patient to patient and depends on factors that are related to the recipient, the donor, the graft that we infuse for the transplant, or the actual transplant procedure. So older age of the recipient can predispose to worse acute graft-versus-host disease, as well as what I mentioned previously, HLA compatibility with the donor, minor histocompatibility, antigen differences, as well as sex difference. In particularly, when the donor is female and the recipient is male, we see there that there is an increased risk of acute graft-versus-host disease. Now, related to the graft, the use of GCSF mobilized peripheral blood stem cells as opposed to bone marrow graft, that predisposes to acute GVHD. A higher stem cell count is predisposing to worsening grade acute GVHD, while the use of T cell depletion decreases the chance of GVHD. And as far as the transplant procedure is concerned, reduced intensity conditioning actually predisposes less to acute GVHD compared to myeloablative conditioning regimen. Now, when acute GVHD develops, depending on the organ or organs involved and the extent that they're involved, we can determine the grade and thus the severity of the acute GVHD. For skin, it depends on the amount of body surface area that is involved. For liver, it depends for the most part on the bilirubin levels. And as far as gut GVHD is concerned, it is related to the volume of diarrhea. So depending on the grade, the stage, then we can determine what the grade is of GVHD, with grade 1, the lowest grade of acute GVHD, being just involving the skin. And this can actually be treated with topical steroids alone. Or you can have grade 2 to 4 acute GVHD, which is treated with systemic steroids. Now, depending on the grade of acute GVHD, we see a higher incidence of treatment-related mortality, with the high-grade acute GVHD, grade 4, of course, being associated with the worst mortality. However, GVHD also demonstrates a potential benefit of the so-called graft versus leukemia effect. And studies have shown that patients that demonstrate both acute and chronic GVHD ultimately have a higher leukemia-free survival and overall survival, while patients that do not demonstrate graft-versus-host disease at all might be spared from this complication and the side effects of treatment. However, they do have significantly higher relapse rates. Now, in order to, the best treatment of GVHD is, of course, the prevention of GVHD. So we're going to talk a little bit about the prophylaxis. And the first step in protecting from GVHD has to do with the use of the donor. So for both acute and chronic graft-versus-host disease, matched sibling donors have a lower incidence of acute GVHD compared to unrelated donors. While GVHD prophylaxis is probably one of the most important interventions in the transplant process, it's the best strategy to minimize graft-versus-host disease. And of course, the immunosuppression we administer protects from graft rejection as well. This prophylaxis decreases the incidence and the severity of GVHD. However, it does not completely eliminate the development of GVHD. And there's a variety of combinations of immunosuppressive drugs that we use to protect from development of graft-versus-host disease. And these include calcineurin inhibitors, such as cyclosporin or tacrolimus, combined with methotrexate or other drugs as well. Ex vivo T cell depletion has also been used. And more recently, I think more frequently, transplant centers are now using post-transplant cyclophosphamide or other forms of in vivo T cell depletion to protect from GVHD. Calcineurin inhibitors such as cyclosporin are a cornerstone in the protection against graft-versus-host disease. They were introduced into our practice since the mid-1980s and were basically a game changer, as up until then, GVHD was a very significant cause of very high grade graft-versus-host disease and mortality. Calcineurin inhibitors are administered from day -1 of transplant. That's 1 day before the stem cell infusion. And for the most part, they are used for prophylaxis up to around 3 months after the transplant. So the question here being in regards to prophylaxis, how much do we administer? So one can be aggressive with the immunosuppression in protecting against graft-versus-host disease. However, the more aggressive prophylaxis might lead to less graft-versus-host, but will predispose to more relapse, especially with the aggressive hematological malignancies, such as the leukemias. While decreasing prophylaxis can protect from relapse post-transplant, however, you would be faced with higher chance of severe graft-versus-host disease. So it is a delicate balance that we try to achieve. More recently, post-transplant cyclophosphamide has been introduced as graft-versus-host disease prophylaxis, and it has been quite successful. This is one of the early publications by Kanarki and colleagues from 2014, where they successfully used post-transplant cyclophosphamide as the sole graft-versus-host disease prophylaxis given at day 3 and day 4 after the stem cell infusion. And what they saw was a significant decrease in acute graft-versus-host disease, in particular the grade 3 and to 4 more devastating graft-versus-host disease, as well as chronic graft-versus-host disease, and without a significant increase in relapse risk. Regarding treatment of acute graft-versus-host disease, acute GVHD must be treated aggressively. Like I mentioned previously, grade 1 isolated skin GVHD can be treated with topical steroids alone, but for grade 2 to 4 acute GVHD, systemic steroids are used, and high doses of systemic steroids in particular for grade 3 to 4. And of course, depending on response, a steroid taper is initiated, as steroids have well-known and significant multiple different complications. Unfortunately, up to 30% of acute GVHD patients are steroid refractory. So steroid refractory acute GVHD is defined as progression of GVHD within 3 to 4 days of initiation of treatment, or no improvement within a week, or an incomplete response within 14 days, or by day 14 of initiation of treatment. In that case, the steroid refractory GVHD is unlikely to resolve with that treatment alone and requires second-line treatment. And unfortunately, these patients have a very poor survival. There's a variety of treatment available for steroid refractory GVHD, and multiple different immunosuppression treatments have been used, including polyclonal and monoclonal antibodies, phototherapy, or even extracorporeal photopheresis. There's multiple studies out there demonstrating some response of these patients, but overall, the prognosis is dismal. Even if GVHD is brought under control, these patients usually succumb to multiple infections. And this sort of underscores why prediction of GVHD is so important. Which brings us to the prognostic methods that can be used in predicting allogeneic transplant outcomes, and in particular, graft-versus-host disease. So pre-transplant risk scores have been developed and validated. However, differences from transplant center to center seem to demonstrate that these prediction scores are not very applicable all across the board. Machine learning algorithms has also been developed in an attempt to predict outcomes such as graft-versus-host disease. However, I think the major player in GVHD prediction is the study of biomarkers. So a few words about biomarkers. And what is a biomarker? By definition, a biomarker is a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacologic responses to a therapeutic intervention. Biomarkers can be very useful also in clinical trials. While in clinical trials, we investigate clinical endpoints that measure distinct characteristics of a disease that reflect the therapeutic effect. However, biomarkers can serve as a surrogate endpoint that substitutes the clinical endpoint and helps even predict clinical effects. Biomarkers in medicine are seen everywhere. Just about anything that can be measured in a patient can be used as a biomarker. We see them as diagnostic tools, such as measurement of blood glucose in patients with diabetes, disease staging, such as cancer markers, and even imaging can indicate prognosis, such as the extent of tumor shrinkage after administration of chemotherapy. Biomarkers, as defined by the NIH, can be categorized as diagnostic, in which case they can help a clinician differentiate diseases with similar clinical presentations. They can be prognostic and help determine the likelihood of developing a particular complication. They can be categorized as predictive, in which case they give information on how a patient will respond to a particular treatment. And they can also be used to measure the response, the adequacy of a response to a certain treatment. Biomarkers can be derived from just about any biological material. Blood, urine, saliva, and imaging can all be used as biomarkers. However, the ideal biomarker needs to be readily available, as non-invasive as possible a method, and easily collected at various time points. And the biomarker source that fits the bill here is blood and plasma. It seems to be the most common source of biomarkers and what is most commonly used in biomarker research. Now, in the development of a biomarker, there are multiple steps involved. The first step being the identification of potential biomarker candidates. The identification phase is usually performed in a small cohort of patients, maybe 40 to 50 patients, where a potential biomarker is identified that correlates with a specific type of clinical manifestation. This is verified in a larger independent cohort. And finally, the qualification phase of testing the impact in a large population, usually multi-center. So while investigating for biomarkers, specifically for graft-versus-host disease, confounding factors should be considered when choosing samples and controls. These involved the grade of graft-versus-host disease and the target organ involved, factors related to the immune reconstitution after transplant, whether the patient is on immunosuppression or not, and concurrent infections, for instance, as well as factors related to sample processing and storage. And when analyzing the impact of biomarkers, covariates should be investigated as well that are related to the transplant and the patient, such as patient age, the primary disease the patient is transplanted for, and donor characteristics such as the donor type and the HLA matching, as well as conditioning regimen, conditioning intensity, and the use of immunosuppression. Now, the ideal biomarker should be both sensitive and specific. Sensitivity is defined as the proportion of patients with a target condition in whom the test is positive, and specificity is the proportion without the target condition in whom the test is negative. Now, a plot of the true positive rate versus the false positive rate of all possible thresholds of the biomarker is the receiver-operator characteristic, or the ROC curve. And the area under that ROC curve is a very commonly used measure of the utility of a biomarker, and it is a number that ranges from 0.5 to 1, with 0.5 demonstrating no diagnostic capability and 1 being the ideal, associated with the ideal diagnostic discrimination. Now, regarding protein biomarkers, specifically for graft-versus-host disease, I'd like to elaborate a little bit on that. Many different immune-mediated proteins related to development of graft-versus-host disease have been studied over the years and found to correlate with the degree of GVHD. IL-12, for instance, and IL-18 promote the Th1 lymphocyte development and acute graft-versus-host disease. And this study demonstrates how IL-12 P70 levels in the first month after transplant are associated with grade 2 to 4 acute GVHD. Other immune cell-derived biomarkers include TNF receptor 1, which in this study was measured at baseline as well as day 7. This is a surrogate for TNF alpha, and it seems that patients whose levels decreased above 2.5 times compared to baseline, these patients demonstrated they developed grade 2 to 4 acute GVHD significantly. Interleukin-6 is also another pro-inflammatory immune cell-derived cytokine that has demonstrated to correlate with the severity of acute graft-versus-host disease. And some other studies have looked at multiple different cytokines simultaneously, such as this one, where the cumulative incidence of grade 3 to 4 acute GVHD was seen in patients with versus without elevated biomarkers by day 15 post-transplant. Anti-inflammatory cytokines also can be useful as biomarkers for acute graft-versus-host disease. For instance, TGF-beta, which promotes the generation of regulatory T cells, that dampens the severity of graft-versus-host disease. However, the elevation of this cytokine can indicate a reaction of the patient's body to the inflammatory response of graft-versus-host disease. The same thing with IL-10, which is a macrophage and Th1 cytokine inhibitor. These levels of these cytokines seem to be increased when GVHD develops. Now, we're not going into deeply to discuss chronic graft-versus-host disease, but these types of biomarkers can also be isolated from the serum, predictive of chronic GVHD as well. So in this study, B-cell activating factor, or BAFF, was investigated in 104 patients. BAFF levels significantly were higher in active chronic graft-versus-host disease patients. And this biomarker also seems to be elevated in other autoimmune diseases as well. Autoantibodies have also been studied in the chronic GVHD setting. This is an older study looking at a small number of patients. However, it demonstrated that patients that had chronic GVHD also had circulating autoantibodies, which control patients did not. Another type of a protein biomarker isolated from the serum that can be predictive of graft-versus-host disease involves tissue injury-derived biomarkers. Elephant, for instance, which is released from keratinocytes, cytokeratin 18 from epithelial cells, reg3a, which is released from damage of the intestinal epithelium, and specifically from Paneth cells, as well as hepatocyte growth factor, and SD2, which is released from endothelial cells. Another potential biomarker is the proteins belonging to the heat shock protein family. In particular, the 70 kilodalton heat shock protein is upregulated in inflammation and autoimmunity, and has been found to be involved in the production of pro-inflammatory cytokines. So this is another potential biomarker that can be studied, or even a potential target for a treatment of acute GVHD. Now, more recently, plasma biomarker panels have been utilized in order to investigate and identify potential protein biomarkers in allogeneic transplant recipients. In this study, antibody microarrays for 120 different proteins were studied in blood samples that were drawn on multiple time points post-transplant and within 24 hours of development of graft-versus-host disease. In this study, 42 patients were investigated, 21 with graft-versus-host disease and 21 without. And among these multiple potential biomarkers, 8 candidate proteins were identified, and using ELISA methodology, they were tested on 424 patients that were separated into a training set and a validation set. And logistic regression analysis helped the researchers derive a 4-marker panel, which involved interleukin-2 receptor, TNFR1, IL-8, and HGF. And these 4 proteins in combination, this panel was predictive with a pretty high AUC of 0.86. Plasma biomarkers in using sort of multiplex panels have also been performed in chronic GVHD. In this study, 35 patients with chronic GVHD were compared with 18 patients without, and 105 candidate proteins were investigated, with 4 lead biomarkers, which demonstrated a good predictive score of almost 0.9. Which brings us now to probably what is the largest proteomics study that is ongoing worldwide in regards to allogeneic transplant recipients and prediction of acute graft-versus-host disease. That is the MAGIC Consortium. MAGIC stands for the Mount Sinai Acute GVHD International Consortium. It involves over 25 stem cell transplant centers, and it provides consistent multi-center monitoring of acute GVHD severity during treatment, as well as its main purpose is to obtain samples for biomarker analysis. So this consortium has enrolled over 4,000 patients, and they've collected more than 100,000 serum samples to date. Our center actually has recently been accepted into this consortium, and we are on the verge of starting to collect samples as well, and participate in this multi-center collaboration. Now, the purpose of the MAGIC Consortium is to investigate biomarkers potentially predictive in acute GVHD, but also to help incorporate these biomarkers into clinical trials. Because of this interest in clinical trials and the standardization of acute GVHD criteria, they've modified the acute GVHD criteria a bit to include things like upper GI GVHD, for instance, and also they've modified how Lower GI GVHD is being assessed. All this is in the context of incorporating these criteria into the clinical trials that are derived from this consortium. Before I get into the results of what this consortium has already published, I'd like to say a few more words about acute GVHD of the lower GI and the mechanisms behind it. So acute GVHD targets the gastrointestinal crypts, which host intestinal stem cells that are found in the crypts of both the small and large bowel. In these crypts also we find the Paneth cells, which contain eosinophilic granules with antimicrobial peptides, as well as the regenerating islet-derived protein 3A, otherwise known as reg3A. And the function of these cells is that they generate proliferation signals for the intestinal stem cells. Also in the crypts, we have innate lymphoid cells, which are in clusters called cryopatches. And these ILCs, they secrete IL-22, which in turn stimulates secretion of reg3A by the Paneth cells and helps expand the intestinal stem cells, which is important when the intestinal mucosa gets damaged, such as in situations like acute GVHD. Now, the histological severity of GI GVHD depends on the damage and the number of the individual crypts that are destroyed. The Paneth cells that I previously described are both targets and shields of the GI crypt against graft-versus-host disease, and the loss of these cells correlates with the increased clinical severity of GVHD. Therefore, the reg3A is released into the bloodstream when these crypts are damaged by GVHD, and the serum levels of this protein increase as the severity of GVHD increases. Another protein axis that can be used as potential biomarkers is the IL-33 ST2 axis. IL-33 is a protein, an alarmin, that is released by damaged cells, and levels are found increased during graft-versus-host disease. And the membrane-bound ST2 suppressor of tumorigenesis, the receptor of IL-33, is expressed on activated T cells as the GVHD progresses. Serum levels of ST2 are powerful predictive markers in severe GVHD in humans. So these two markers in particular, they're of particular significance. They were assessed along with a few other potential significant proteins in this study launched by the MAGIC Consortium, a multi-center study which basically comprised a training set of 492 patients and a test set of 300 patients, where samples were collected within 48 hours before or after treatment was started for acute GVHD. So they focused just on a handful of potentially significant biomarkers: IL-2 receptor, TNFR1, reg3A, alafin, and ST2, measured by ELISA. And among these, ST2, reg3A, and TNFR1 performed the best. So based on those three serum biomarkers, a prognostic score was developed using this algorithm, which calculates the probability of non-relapse mortality. And depending on the probability of non-relapse mortality, they were categorized into these three groups: Ann Arbor 1 with an NRM of less than 10%, Ann Arbor 2 of an NRM of intermediate non-relapse mortality, and NRM over 40% for the group called Ann Arbor 3. And what they demonstrated is that these groups, Ann Arbor 1, 2, and 3, were predictive of non-relapse mortality and overall survival in the training set, the test set, as well as the validation set, while incidence of relapse was not affected, demonstrating that these biomarkers predictive of non-relapse mortality due to GVHD had no connection to the graft versus leukemia effect. These Ann Arbor groups, these prognostic groups, also were predictive of complete remission or partial remission of acute GVHD by day 28. And this was seen again in the training set, the test set, and the validation set. Um, and what was also really interesting was that even in the low-risk group of acute GVHD, again, these Ann Arbor groups were able to stratify into high risk of death and low risk. So this algorithm demonstrated the ability to define the risk despite differences in clinical severity. And that means that even in a more clinically severe acute GVHD, a low Ann Arbor score means that we can taper the steroids sooner, while a high score would benefit from more intense immunosuppression. In a different study, again by the Magic Consortium, this involved patients transplanted from 2005 to 2015, and they had provided blood samples for biobanking at 7 days post-transplant. Again, we had a large training set and a test set, as well as a validation set, looking at SD2, Reg3A, TNFR1, and IL2 RA by ELISA. And they found that the SD2 combined with Reg3A measured at that time point best predicted 6-month non-relapse mortality, stratifying patients into high risk and low risk groups. And this was seen again in the training set, the test set, and the validation set. And interestingly, this was also consistent in the subgroups, depending on whether the donors were related or unrelated, matched or mismatched, reduced intensity or full intensity conditioning chemotherapy, and irrespective of age. So they developed, using just these two biomarkers, ST2 and Reg3A, a refined Ann Arbor scoring system predictive of non-relapse mortality. Now, the ability to predict using these Ann Arbor groups is important, as it can be used to identify high-risk patients in clinical trials such as this one. So this was a biomarker-guided preemptive assessment of steroid refractory graft-versus-host disease patients that were treated with alpha-1 antitrypsin in previous stage 1 to clinical trials. These patients demonstrated a response to alpha-1 antitrypsin. So this study wanted to investigate further and see if stratifying preemptively the high-risk patients can lead to a lower frequency of steroid refractory graft-versus-host disease. Unfortunately, this trial failed. So despite the identification of the high-risk patients, this drug did not decrease the chance of steroid refractory graft-versus-host disease. However, as a proof of principle, this demonstrated how using biomarkers we can guide clinical trials and develop clinical trials to identify treatments that can prevent steroid refractory GVHD. Now, before I go on to more multiplex methods used in GVHD prediction, I just wanted to differentiate between the transcriptome and the proteome. While the transcriptome looks at the genome or the mRNA complement found within a cell, the proteome characterizes all the proteins of a cell in terms of localization, post-translational modifications, and interactions at any given time, and thus gives a sort of snapshot of what is currently going on in a patient and the pathophysiological mechanisms that are at play. Dale has already shown you an introduction to the multiplex proteomics using the Olink method. The proximity extension assay is an immunoassay panel that's coupled with DNA methodology. It's highly specific, high multiplex, rapid throughput biomarker analysis, which uses matched pairs of antibodies which bind to a specific protein, and each antibody carries a DNA tag. The matched DNA strands in close proximity, they hybridize, and combining this dual antibody binding and DNA barcoding, this provides a scalable method with very high specificity, because only the correctly hybridized tags are extended and amplified. And we used at our center this method in order to investigate and to screen for potential biomarkers in acute graft-versus-host disease patients following transplant. This was a study done by myself and Dr. Ivan Pasic as principal investigators, and in collaboration with the Mount Sinai Hospital laboratory here at the University of Toronto. And what we did was we looked at 28 patients which underwent allogeneic transplant for acute myeloid leukemia in first complete remission. We preemptively collected samples from day -6, day 0, and different time points post-transplant. And we investigated 17 patients that had developed grade 2 to 4 acute GVHD and compared them with 11 patients without graft-versus-host disease. And here's just a snapshot of the two patient populations involved in the study. After an initial study, we did a pilot study using only 10 patients using the 1000 multiplex Olink platform. We identified 552 proteins, which we would use for a more extended cohort. These involved the 7 Olink panels, the cardiovascular, 2 regulation, metabolism, neuro, exploratory, neurology, oncology, and immune response panels. So what we did was, using this more limited Olink panel, we performed analysis of samples at baseline and at the time point right before development of graft-versus-host disease in the GVHD cohort, and we compared them to the control cohort where samples were analyzed at baseline and at the last time point that a sample was collected. And we performed 2 different types of analysis of the results. One was an individualized analysis where protein candidates with an equal or more than 3-fold increase in protein expression post baseline compared to pre in patients with GVHD. And the other analysis we performed was a paired t-test followed by logistic regression, after which we identified candidate protein biomarkers of significance. So this was with the individualized analysis. This heat map demonstrates which proteins were significant and had a more than 3-fold increase just before development of graft-versus-host disease compared to controls. And in the logistic regression analysis was performed on these proteins, which were found to be most significant based on paired students t-test, and ultimately gave us these 4 proteins of significance: BTN3A2, SLAMF7, IL1RA, and DAB2. So all 4 of these had a significant predictive value in regards to prediction of onset of acute GVHD. And interestingly, all 4 of these are proteins that are somehow related to immune responses. SLAM family number 7 is found on, it's a receptor that is significant in innate and adaptive immunity and upregulated in immune diseases, in autoimmune diseases. Interleukin-1 receptor antagonist is the naturally occurring antagonist to pro-inflammatory cytokines, IL-1 alpha and beta. Butyrophilin subfamily 3 member A2 is the transmembrane molecule. It belongs to the immunoglobulin superfamily and is expressed on most human immune cells. And DAB2 is a protein that may be involved in the development of immunological tolerance and anti-inflammatory responses. And what we found was, combining these 4 into a 4-marker panel, the AUC of this combined panel was quite high at 0.903 and quite significant as well. So next steps regarding our research is validation, of course, in a larger cohort, which is something that is currently underway. We have added patients to our cohort, and we would like to investigate further, looking at a larger, more extensive Olink panel involving 3,000 proteins. Ultimately, we would like to focus on a limited custom panel where, having identified some proteins of significance, we can use them as an early predictor of acute GVHD that can be widely applicable, not just in our cohort, but in multiple transplant centers as well. In conclusion, biomarker research continues to be an exciting and dynamic field in allogeneic transplant and GVHD research. Serum protein biomarkers may prove to be a promising clinical tool, but there is much more work that remains to be done. And at this point, I'd like to thank Dr. Pasic, my collaborator, as well as Dr. Ram Namputhiri and the team at Mount Sinai Hospital. Next door to us, that's Dr. Diamandis, who is the director of the biochemistry lab, and his collaborators, Dr. Prasas and Annie Wren. Thank you very much for your attention.
Thank you very much for a very interesting talk. For those of you who may have questions, there's a Q&A box that you can feel free to submit questions. I had one. You showed some early work, right, with IL-2RA, with TNF-R1 and IL-8. Was that those particular markers much further down in the treatment course? And then your particular markers are for the early predictors, is that correct?
Sorry, can you say that question one more time?
Sure. So in an earlier paper from like earlier markers, there were markers such as IL-2RA and TNF and IL-8 that were like predictors around the severity of graft-versus-host. And in your work, were the samples that you tested earlier in the disease course? Thus, you got different markers?
That's so these particular markers, they didn't stand out. They're well-known inflammatory cytokines.
Right.
The time points that we chose were calendar driven. We didn't collect samples at onset of treatment or at diagnosis of graft-versus-host disease like some of these other studies. So as an exploratory study, we just wanted to look at potential biomarkers that really we would see a very significant difference in expression that stand out, that potentially we can focus on. These biomarkers that you mentioned aren't ones that stood out. So or compared to the biomarkers that we identified. It's a different cohort of patients. It might not just be related to different time points. It's a different cohort of patients, different diseases. There are a lot of confounding factors, which is what makes biomarker discovery really difficult. What I think helps us determine that we're on the right track, at least, is that the biomarkers that we identify that stood out are immune mediated, are immune related. They're related to the immune system for the most part, and some of them are pro-inflammatory. But the purpose of our study is to investigate potential proteins using this multiplex panel that other researchers have never even looked at. It's a little bit of a fishing expedition, but I guess it is the only way to really identify a protein biomarker that would not otherwise have been identified. And it is good to see that what we have identified, biologically, it does make sense.
Yeah. I mean, it was interesting, right? You going back into the literature and showing prior work and intensive work being done. And now you made it clear, right? This is sort of after diagnosis, after treatment course was begun, right? Whereas you're looking at, a very different scenario where it's very early on in the disease course, or meaning right after, like you mentioned, calendar driven. Calendar driven meaning a certain number of days post-transplantation, then you take samples. Is that correct?
Yeah. I mean, some of the studies I previously mentioned do focus on certain time points like day 14 or 30 days after transplant. Basically, we're doing the same thing. But
Mhm.
what we really want to do ultimately is identify biomarkers that can be drawn at day 14 or maybe day 21 after transplant, even while the patient is still inpatient, that can tell
Right.
us that the patient is very likely to develop graft-versus-host disease and thus help us determine certain interventions that we can do to prevent that
Yep.
from happening.
Yep. And
That is,
there you talk about the. Oh, go ahead.
sorry, go on.
Oh, there, that's true personalized medicine, right? Where you're actually looking at the response of the host, right? In response to potential danger and relative risk. I mean, that was, quite informative. And yet, in terms of some of the graphs that you showed, as far as risk at different levels, but nonetheless, the discrimination wasn't 100%, right?
No, it was not. It was not 100%. But
Yeah.
no,
I mean, in the
that's
earlier
why
work.
that's why I believe that possibly a panel. It's not just one specific biomarker that's going
Yeah.
to be the magic bullet.
Right. Right. And this idea of multiplexed or multiplexing, right? The prior work done by singleplex ELISAs, it naturally limits how many markers you can look at the same time. Whereas with the scalable technology, we're able to actually look at multiple markers. Here you have 4. You mentioned intending to naturally validate this as well as expand the sort of net by which you're fishing with, right? But nonetheless, this is very illuminating in terms of the scope of the problem. When I saw, 15 to 20% mortality, wow, you're working on a problem that has clear impact, right? In terms of literally hundreds and thousands of individuals, right, who have this chronic condition. So any final comments you'd like to make?
Yeah, I mean the prediction of post-transplant outcomes, and particularly graft-versus-host disease, it's
Mm-hmm.
kind of like the holy grail of our field. And
Mm-hmm.
see, these numerous studies are published, and some centers are validated, and other centers, the
Mm.
reproducibility isn't that great. The search is ongoing for the perfect biomarker. Like I mentioned previously, I don't believe that it will be just one protein. It's very possible it will be a
Mm-hmm.
combination of proteins. The usefulness in multiplex proteomics is in the initial phase, I believe, the
Mm-hmm.
investigation, the discovery phase. But ultimately, you cannot analyze thousands of proteins and use this
Yep.
as a fingerprint alone of what patients are going to how they're going to react and respond to treatment. I think a handful of proteins in a limited panel is probably what we're striving for going
Yep.
forward. But the multiplex
Yep.
proteomics in the initial phase, without that, there could be proteins out there that are potentially useful,
Sure.
and they can go undetected.
Yep. Which is why we're, I think, at a flipping or an inflection point in terms of interest in protein biomarkers again. After all the work in genomics, now people can take a look at the circulating proteome in a new way that actually is scalable. By that, I mean, from the point of view of finding new markers, right? In terms of so many markers are still yet to be characterized. I mean, the 4 that you brought up, I'm completely unfamiliar with, right? In terms of BTN and SLAM F7 and DAB, and I just like, wow, that's really, really interesting from a biological point of view, but from a sort of potential diagnostic point of view, really exciting times because, right, the power of being able to discriminate in the prognostic sense early on in the disease, where, right, treatment courses, there are plenty of different treatments. I mean, you went through so many of them that there's lots of different ways to go with this once the data is in hand, right? Do you go aggressive on the treatment? Do you give it a light touch with all the attendant side effects or with complications, right? Being able to choose a simpler course of treatment. Well, thank you, Frank, for just a really interesting talk. Thank you, audience, for attending today. Certainly, if you're interested in Olink, it's olink.com, and take a look there. LabRoots, I want to thank LabRoots for hosting this webinar today, and have a great day.
Thank you very much, Dale. Thank you all.